I must congratulate the people who are shining this cause, Cuthbert and the rest of the team. We thank you very much, and we thank you for being the team leaders and showing us how it's done. Tonight, it's just a simple sharing. It's just a simple case that I'm sharing. And the emphasis about this is lung ultrasound and the chest X-ray. Which one should we do, what and when and how? Particularly, I'm not going to discuss a lot of lung ultrasound. That will be a lecture on its own. But in here, let's see what is in there. Without wasting a lot of time, most of us, be it radiographers, imaging technologists, sonographers, we have not had much of that clinical perspective, except those who, the medical officers or people who have had that perspective. But what I have noticed, excuse me, the practice predominantly is very many of us are practicing what we are taught by our seniors. The approaches we are trying to use is because of what our seniors have shared with us. But our seniors do not give us the approach of how this comes about. Now, this particular slide is to show us the approach that will help us in redefining and refining our work. Diagnostics, indeed, we deal with pathology, but how do we get to know this pathology applies here? This is this, this is that. With the experience and through some further reading and interaction with the seniors, this approach demonstrated here is what I'm using. It is reliable. It is giving me good stuff. It is giving me good things. And I thought I should share it. So part of the gist of the content for this presentation is in this slide. So we deal with pathology. Whenever you want to talk of any pathology, or when we talk of disease, the first thing you should do is define the disease. When you define the disease, then find about the risk factors associated with it. What are the risk factors that will cause this disease? Then what is the clinical criteria? How do you come about to know this disease is this? How does it present? The signs and symptoms? And epidemiologically, what are the exposure factors, or what are the exposures to this disease? Exposures, you may as well take it to be some of the risk factors. And then what are the steps that this disease develops eventually to become that actual disease, the pathophysiology of that disease. Now, when you have defined the disease, you know the risk factors, you know the clinical criteria, or the signs and symptoms and the presentation, and you have understood the pathophysiology of that disease. Investigations becomes very easy. The quickest example I want to give here is when we talk of pneumonia, we have typical and atypical pneumonia. These two terms, why some people ignore them, but when we talk of pneumonia in a person who is immune suppressed, ISS, and someone who is immune competent, when you go to the deep pathologies, these two people respond differently to any pathogens. So for us to do investigations, we must understand we are dealing with someone immune competent or someone immune suppressed. These two people will offer different appearances. So this approach, personally for me, it has helped me. It has opened my eyes. It is very important. Look at it critically. You can start to practice it. Be it whether you are doing ultrasound, X-ray, CT, MRI, you start doing this. It will open for you what seems to be hard. Now, for me to demonstrate this, I have this case that I'm going to use. We have a 50-year-old male who was a smoker, and he developed shortness of breath for about 2 weeks. Goes to the nearby clinic, and the clinician there says, this is asthma. And he was given an inhaler. I will not go into the details of how bronchospasms, we know what all that is. I will not go into the details. So the inhaler is to stop the asthmatic attacks. But 3 days later, this gentleman is worsening, and now he's having fatigability, no improvement. Now he comes to a different facility, which is a facility actually we were in. I must say this work is a collaboration between me and my colleague, is a physician, my friend. And this is how we shared this case. So he sends for a chest X-ray. And from the chest X-ray, this is what is demonstrated. On the left is the PA view, and on the right is the lateral view. But like we can see, what we can clearly demonstrate from the PA view is the prominent bronchovascular markings. And that on the right here, there is tendency to coalescence. There is tendency to coalescence here. Just a moment, I need to put this away. Oh. Just a moment, I need to. Okay, so here, apart from the coalescence of the bronchovascular markings, honestly, there is nothing much to read out of this. Those of you who have had pattern recognition, when it comes to the chest, when you look at the cardiac shadow, it looks more or less of normal size. Of course, we have to do the cardiothoracic ratio, but in this patient, it was within normal. You look at the hemidiaphragms, they look smooth. And you look at the costophrenic angles. Well, when you look at the right costophrenic angle, it doesn't give you an impression so much that there is something wrong. Even when you look to the left costophrenic angle, it doesn't give you that semblance that something is wrong. But when you look at the rest of the lungs, there seems to be normal translucency. You come to the lateral, it's more or less the same. However, when you look at the lateral, the costophrenic recesses, somehow, somewhere, they are not sharp, but you cannot clearly define this. Excuse me. You can't clearly push this out. I mean, you can't clearly identify it. So the question is, are the costophrenic angles or the recesses clear? Are they sharp? This depends on what you're seeing. Some will pass it normal, some will say no. Depending on your experience, the eye sees what it knows. So is there pleural effusion or pleural thickening in this chest X-ray? Depending on what you're seeing or what you can interpret out of this, that's up to you. But let's see what goes on. So the interpretation from this, from the person who reported that chest, it was regarded as interstitial pneumonitis because there is prominence of the bronchovascular markings. So it is given interstitial pneumonitis. Some call it interstitial syndrome. Now, when they mentioned interstitial syndrome, the differential was more or less of chronic obstructive pulmonary disease. But we know the signs of this. This case here is not a clinical or a classical case for COPD, but it's given interstitial syndrome. Fine, granted. Partly because this gentleman was a smoker, and we know smoking or any history of smoking will likely lead you to chronic obstructive pulmonary disease. But we were not contented with these findings. So the physician sends for D-dimers, and they were found to be elevated at 1.9 micrograms. The normal is supposed to be less than 0.5. Now, in most cases, excuse me, when you find the D-dimers elevated, very many people will think of pulmonary embolism or some blood clot somewhere. And immediately, a chest CT scan was sent for to rule out pulmonary embolism. And what returned back, there was no pulmonary embolism. There was no sign of pulmonary embolism. Instead, there was some small effusion and pulmonary edema. That is what the CT scan brought back. Now, because of the pulmonary edema, this is not specific. These findings of subtle effusion and pulmonary edema are not specific. What is causing this? But fortunately, we have ruled out pulmonary embolism. Now, these images are not of this particular patient. These are here for demonstration purposes. Just to demonstrate the ground glass appearance on the image on the left, the actual image, and some small effusion. The image on the right, just to show you some bit of parahilar consolidations in the pulmonary edema. I reinstate these images are for demonstration purposes. They are not for this patient who are unable to get the CT images for this particular patient. So after here, we thought, why don't we go for lung ultrasound? Part of the gist of the matter is again in this slide. This is actually the take home. We started with a chest X-ray, and there's nothing much we could read out of it apart from the so-called interstitial syndrome. But we have seen the D-dimers are elevated, and because they're elevated, we go to the CT scan, want to rule out pulmonary embolism. Fortunately, there is no embolism, but there is pulmonary edema and some pleural effusion. Now this comes back. What do we need to use between the chest X-ray and lung ultrasound? Which one should we use in cardiac disease or in heart failure? Now, by research, X-ray or the chest X-ray, excuse me, only has 56% of sensitivity to any cardiac disease. But lung ultrasound has 100%. So anyone who knows these statistics, immediately you see that interstitial syndrome, that chest X-ray is not providing us enough. Thankfully, the CT has given us further information. There is pulmonary edema and there is small effusion. Very few can pick effusion from that chest X-ray. If I could go back slightly, it is very hard for many of us to pick out that there is pleural effusion in this chest X-ray or there is pulmonary edema until we did the CT scan. But we know the radiation. How much radiation are you going to receive for a chest CT scan? Now, this is where lung ultrasound comes in. Lung ultrasound can avoid that so much radiation from the CT scan. I will provide an article that compares between chest CT scan and lung ultrasound. Understandable, the CT scan is the reference for chest pathologies. But when it comes to cardiac, let's see what lung ultrasound has to offer. And indeed, when we did the lung ultrasound, we confirmed there's pulmonary edema and there is pleural effusion. Now, on lung ultrasound, what are we looking for? In lung ultrasound, we basically use artifacts to tell pathologies. There are over 10 artifacts, which we'll discuss later, not in this presentation, and we'll see their appearances. But particularly for this presentation, you see this hyperechogenic vertical artifact. This is what we use if we want to tell there is pulmonary edema. Now, in this case, you'll find more than 5 lines of this kind, what we are calling the multiple B lines. So this is what you're going to get when you see the image playing. You're going to see so many multiple, so many lines. Usually we say more than 3, but in some cases, or in good classical cases, you'll have more than 5 B lines. Once you have these more than 5 B lines, then assuredly you are dealing with pulmonary edema. Now, whereas the chest X-ray did not demonstrate to us this pleural effusion, or it is small, or one could have mistaken it for a pleural thickening, the CT scan showed us it is small effusion. But if you look at this image here on the left, the video playing, I doubt if you'd call this small effusion. We have, this was taken on the right side. This is the spleen here, and you can see part of the lung peeping in there. The depth here for this pleural effusion is more than 2 to 3 centimeters. This is a lot of pleural effusion. We did not demonstrate this on the chest X-ray. Even on the CT scan, it was showing small effusion. So we started with a patient who was diagnosed for asthma, but the management did not work out. We did a chest X-ray, or a chest X-ray was done. It did not show anything so much remarkable until the D-dimers were done, they are raised. Then the CT scan alerted us there's pulmonary edema, there's pleural effusion, and lung ultrasound is confirming to us, yes, there is pulmonary edema. And what you are calling small effusion is not actually small effusion. This is not small effusion. This is about actually more than 3 centimeters deep. So that pulmonary edema and the pleural effusion took us to do more further evaluation. Now, we went for the IVC. We know the IVC responds to Valsalva maneuvers, respiratory cycle. But this IVC is not responsive to any respiration. It's not collapsing. Now, once you find the IVC not collapsing, then you start to think something is not right in the right cardiac or heart chambers. Depending on your expertise, as in imaging, all those who have done echo, we mostly use the IVC, but some people will use the jugular vein, but you'll find the same findings. There's no collapsibility. So once we found there's no collapsibility of the IVC, then it means there's something not right in the right heart chambers. And we ended up doing an echo. And this is what we find. There is left ventricular failure. The ejection fraction is less than 45. In our department, we use the normal range is more than 50, above 50, between 50 to about 80 is the normal range. This was 41%, with a fractional shortening of about 19. So looking at the image on the left, subjectively, those who are experienced in echo, you can tell there is dilatation of the left ventricle. There is a mild dilatation of the left atrium. Yeah. And when we go to the image on the right, we found there was mitral regurgitation and aortic regurgitation. This. Now, imagine this is a patient at first who was managed for asthma. But eventually we did the chest X-ray and it's showing interstitial pneumonitis. Of course, when you say interstitial pneumonitis, this patient is going to be managed possibly with antibiotics. But what are they going to do for those who have done clinicals for the physicians or for the medical officers? You are giving a patient with heart failure, you are giving them antibiotics. What are you restoring the situation? Suddenly not. So how do we handle and clerk our patients? This is where we are ending from interstitial pneumonitis to pulmonary edema, pleural effusion, and finally into left ventricular failure or heart failure. Now, what informed us finally to come to the echo? We go back to the first slide, understanding the steps on how we identify pathologies. What are the risk factors? How do these pathologies present the clinical criteria of how we come up with these pathologies? So eventually we end up with mitral regurgitation, aortic regurgitation, and of course left ventricular failure. Yes, like we saw, the IVC is not collapsing. There was also tricuspid regurgitation. We know where there is regurgitation. Thankfully, this was not so severe. The regurgitation was not so severe. But the tricuspid regurgitation causes ventricular increased pressures and arterial pressures, which ends up affecting the IVC and the SVC. That is why we are not getting collapsibility or response to respiratory maneuvers. So this patient was managed for heart failure, and within 4 days was discharged and was very comfortable. And as we speak, the gentleman is going on with his work, he's fine. So what am I trying to share here? How do we receive and triage our patients? We have seen from the first clinical diagnosis as asthma. 3 days later, the man is worsening. Chest X-ray done, interstitial pneumonitis, but the D-dimers are raised, so we opt for chest CT scan, which turns out to give us pulmonary edema and pleural effusion. No pulmonary embolism, thankfully. Otherwise, this patient would have died a long time ago. But thankfully, we have also rescued this patient by going ahead to do lung ultrasound, which shows us actually this pleural effusion that you are calling small, it's much more. But since the rest of the lung is normal, apart from the pulmonary edema, we finally ended up doing an echo, and lo and behold, the left ventricular failure is what we find. Patient is managed and is fine and well. Take home, not all our clinicians understand the role and the extent of imaging. I used to take this for granted. I expect every doctor to understand when to use a CT scan, when to use a chest X-ray, when to use an ultrasound. But please, dear friends and comrades, do not take that for granted. I've even worked with professors whom we have quarreled, but because you guide them, because you are the technical person who understands what imaging is and its perspective, they appreciate the end result. So be the guide to imaging. You understand each modality limitations. If the chest X-ray is not adequate, either opt for lung ultrasound or the CT scan. You are the person to advise and guide this. Now, finally, lung ultrasound is not common to many of us. But part of what is informing this presentation is to entice us, to ask us to look at lung ultrasound. Let us interest ourselves in it. Let us know what it is. Where can we use it? How is it utilized? What is it? What will it show us different from the other imaging modalities that we have? I can comfortably tell you, when it comes to cardiac diseases, lung ultrasound will give you much ease compared to the chest X-ray. Is lung ultrasound about to replace the chest X-ray? Certainly not. We know in all imaging, the biggest percentage of the examination that is done is the chest X-ray because it is the start point. But like we have seen, it has its limitations. We could not demonstrate how much pre-refusion there was. But we saw in the ultrasound, it's much more than what one could imagine. So, dear friends, my little sharing tonight is to entice you into lung ultrasound. That is one. Maybe we'll have a lecture next time about lung ultrasound. For those of you who are able to get someone who is doing it, please get close to them and learn from them. Routinely and commonly use lung ultrasound, especially when you suspect cardiac diseases. It will make your life simple. As I wind up, let me give you another example. We had a gentleman who had persistent cough, a young gentleman of around 34, persistent cough, but he had a bad odor of his breath. So we do the chest X-ray, and there is homogeneous opacification of the hemidiaphragm. Now, in my department, any chest X-ray where I see any suspicion of opacification, be it small, I do lung ultrasound. Now, this particular gentleman, we found out he had very thick echogenic fluid collection. At aspiration, it was found to be pus, empyema. And the aspiration was done with a pump, or vacuum pump. A needle could not pull it out because it was so thick. But the common mistake is the chest X-ray will say maybe pre-refusion. It is difficult to tell the difference between pre-refusion and an empyema on a chest X-ray. But I can comfortably tell you on lung ultrasound, it's very easy. Now, why are we doing all of this? Yes, there could be some little bit of cost, but we need to save a life. And saving a life must be informed by evidence. The evidence is showing lung ultrasound is a good supplementary to the chest X-ray. It actually saves you a lot. If we had started right away from lung ultrasound, would have avoided that so much radiation from the CT. Thank you very much. Go and be disciples of lung ultrasound. There's this small article. This article will give you the chest X-ray, the lung ultrasound, and the computed tomography in congestive heart failure. You will enjoy it. It will give you a very wide spectrum of what you can look at, the steps and the methodology and how you can come up with this. I thank you very much. This is the little I had for you this evening. Thank you very much.
Thanks a lot, Mr. Vitus.